Hi, I'm Eric Prystowsky. Welcome to another segment of EP on EP. I'm delighted today to have a colleague for many years and one of the leaders in our field, Dr. David Wilber, with us for this interview today. And David has had many titles, but currently Director of Electrophysiology and Professor at the Cardiovascular Institute at Loyola. David,
Correct.
Welcome to the show.
It's a pleasure.
Thank you. So there's so many things we could talk about, but I'd like to concentrate on idiopathic VT because you've made so many inroads there. So let me start with something sort of in quote simple. You were one of the first to come out with algorithms for how to figure out epi versus endo. But I'll remind you, you gave us grand rounds at our institution several years ago, and you weren't negative, but you were more realistic. So
Yeah.
maybe you could educate us on the value and tricks you've learned for the ECG.
Yeah, I think that the biggest challenge is that people get very attached to their algorithms and tend to, as humans do, forget the ones that don't match and just remember the ones that they got it directly at the spot they had associated with. So I think that we started very early that right ventricular outflow tract was something we're interested in locating where it was, whether it was free wall or on the septum with the left ventricular outflow tract. And I think that what we realized is that although that was a useful guide, you could often be wrong because there's so many variations in heart orientation and several other things. It's useful as a first approximation. So when we first started looking at epicardial VT, I think one of the things was there was only a handful of cases at the time. They accumulate over a period of a few years, but we noticed some things, and one of the most remarkable is that oftentimes that the actual morphology of individual leads and that sort of thing were actually very similar to what you found in the endocardium of the right ventricular outflow tract. And so we struggled for a way to find out if there is some other general criteria that you could use. For example, you often saw no R waves in V1 and V2, which is something you find very typically in patients who have endocardial right ventricular outflow tract. So how could you possibly distinguish that from something that's in the AIV, which is only a few millimeters away often, or even in the right sinus of Valsalva, which is something else that you can often see associated with a small or no R wave in V1 and V2. So one of the things that made sense is that if it was epicardial, it had to not engage the His-Purkinje system or did it at a very late phase, so you'd expect the QRS to be longer. So that was the sort of hypothesis that we tested, is that. And the other thing was clearly that you needed to normalize it for the QRS duration sort of as a percentage, simply because there's so many differences in QRS amplitude and duration just related to body habitus and that sort of thing. So it turned out that in our initial survey of the 12 or 13 first patients that we saw that we ablated from the coronary veins, it was almost 100% sensitive and very specific, 96%. So interestingly, we re-looked at that in that instead of having only 13 patients and a handful of others, we looked at now 200 or 300 patients about 2 or 3 years later. So sensitivity fell down. Specificity fell down, but in predictable ways. For example, that you often got fooled. Sinus of Valsalva, which is still sort of technically an epicardial, right, could have this very long MDI, is what we called it, and occasionally, if the heart was rotated, or if we had one patient that actually had an aneurysm, a very small aneurysm of the right ventricular outflow tract, which actually put it further to the left in the chest. Wow. And so in that case, it met the criteria. So a lot of it has to do with some very specific variations in patients. So I became a little more ECG skeptic. It's wonderful, right? We all trained in EKGs. Right. We all want to have these specific signs, and we remember being very impressed by professors that told us about Cabrera's sign or a variety of things that indicated a very specific pathology. But as it turns out, it's like everything. It's a first approximation. You get fooled a lot, and if you stick pig-headedly to it's got to be there because that's what the EKG tells me, you're going to be wrong. And it sort of comes to my, I guess, second, I think, recognition or realization for me is that it really is all about mapping. And of course, that was one thing to say when you had point-by-point mapping, and now but you have these wonderful mapping tools with the rays and that sort of thing. They're challenging sometimes for the anatomy of the right ventricular outflow tract as you go up above the pulmonary valve and that sort of thing. But that density can get you very quickly where you need to go. And you really do see, although there have been some suggestions that occasionally there's a breakout point that's a little bit different from where you see early activation. Some of that's the artifact of the mapping system that was used. For example, you remember in the early ESI days, that was a suggestion. And so now it really, I think it's very clearly about that, about mapping density. Sometimes the right ventricular outflow tract ones are very clear, but the other things that we've learned besides just focusing on activation are these tiny little potentials. So that comes to do now with the...
So let's stop you just before you go there. I just wanted to summarize quickly the issue of the ECG.
Yeah.
I've said, because I grew up in the WPW era, that was my thing, and I've always taught that you should look at it as getting you to the right street, but you still got to hunt for the house, right? So that's kind of what you're saying.
I think so.
You know, kind of where you are.
Sometimes it's the right block.
Exactly.
It's not even a street.
So we have some time left. Let's talk a little bit about the mapping you said and the small potentials with the little time we have left.
Now that we have small electrodes in small inter-electrode distances, so different than the catheter we use to ablate, we recognize that in some of these locations, particularly in the sinuses of Valsalva, underneath the aortic valve in the LV summit, and perhaps even in the areas around the papillary muscles. These are often challenging sites to ablate, but even there you get insights from these tiny potentials that precede the larger massive activation, sometimes by 50 or 100 milliseconds.
So
and those can be very helpful.
How do you distinguish what's far field when you get those? I know what the potential you're talking about versus local. Do you have a trick to do that, or you just map around?
I think, some of it's obviously the frequency, and whether it needs to be high frequency, very discrete. And oftentimes, and these are where you can get fooled by the unipolar electrogram, where the unipolars where the massive LV activation starts, but if there's a small fiber, there's an isolated, something that's isolated by connective tissue, even in the normal heart, then in fact you may have that potential precede by quite a ways. I don't think that pacing will necessarily do it, and in fact, one of the things we've learned that pace mapping, particularly in the outflow tracts, can be very deceptive because
you published that years ago.
There's preferential fibers that can take things so that the earliest activation may actually be in the right ventricular outflow tract, which can be a centimeter or two away from where you can actually ablate these as signified by these high frequency potentials.
So if I have to summarize your wonderful approach here, it would be this, and tell me if I'm right or wrong. It would be the Carpenter's approach. Right? Measure twice, cut once. So what you're really saying is, and I think it's a valuable lesson, start with the ECG, get you in, like you said, maybe the block, but then you're going to have to be realistic about it. When you get inside the heart, you have to have an open mind, is what you really say. Don't be perseverating, I guess, in an area you thought was the ECG if it turns out not to be. Is that fair?
Yeah, and I think maybe the learning while burning, which was a very sort of clever thought a long time ago when we were learning about these arrhythmias and their mechanisms. I think now that much of this has been defined, we know you need to look everywhere. For example, for most of our idiopathic VTs, we'll take a very quick look at the AIV-GCV junction. You can get a small mapping catheter into that area very simply in virtually all patients, and then you can rule out very quickly if this is likely to be epicardial
Very
or not.
interesting.
And in fact, if it's not even pre-onset of the QRS, you already know you're done.
Right.
And it's even unlikely to be in the sinuses of Valsalva in that sense. So you already know that with a left bundle, and it's particularly if it's a failed ablation from before, and you think, well, maybe because it's somewhere in the LVOT, you can actually rule that out within a couple of minutes by just sticking a catheter up there.
So I'm going to ask you at another time. We're going to do another session with you because you've had worlds of experience in this area, and maybe we'll concentrate there on ablation techniques and some tricks there. But it's been wonderful as always, David. Thank you
Pleasure.
for
All right.
participating.
Thank you.